Welcome to this video on the Glossary of ILD patterns. I am Dr. Anshu Maneja Arora, and in my previous video, I discussed about the latest ERS guidelines on IIPs. This was a revolutionary guideline statement that has really changed the concept in which we are noting various patterns in ILDs. So, this video is a one of a kind video where I will be taking examples directly from the guideline paper so that you can essentially compare the various patterns you see in your clinical practice with the standard ones mentioned in the literature. This way, you have a ready reckoner for most ILD patterns, whether radiologically or histopathologically. So, let's make ILD easier. Easier. So let's first start by understanding what are the various patterns that have been described in the latest guideline. If you have not listened to the previous video, then I have discussed in detail the major changes in this latest ERS statement paper. Firstly, we'll be talking about the UIP pattern, which is retained in the 2025 guideline. Secondly, the NSIP pattern. Third, bronchiolocentric interstitial pneumonia or BIP pattern, organizing pneumonia, diffuse alveolar damage, pleuroparenchymal fibroelastosis, and some combined patterns along with rare patterns. Now, when we talk about the UIP pattern recognition, we know that UIP is the core pattern of IPF. But UIP is not seen only in IPF. It is also seen in advanced connective tissue diseases. It's also seen in advanced hypersensitivity pneumonitis. So, UIP pattern essentially has a poorer prognosis, and its recognition is really important. So, here, remember three main characteristics of UIP pattern. Number one, basal subpleural. Number two, honeycombing. Honeycombing is characteristic of UIP, and it is honeycombing which segregates a UIP from a probable UIP. Traction bronchiectasis. Tractional dilatation and bronchiectasis is classical. Fibroblast foci on pathology. So when we see a basal subpleural predominant pattern of interlobular septal thickening, traction bronchiectasis, and honeycombing, which is a must for UIP pattern, we would call it UIP. So let's look at the first images taken from the guideline statement. This is a comparison of the UIP pattern versus probable UIP pattern. So usual interstitial pneumonia versus probable UIP pattern. What is the difference? Only one difference: honeycombing. Honeycombing is more classical in a UIP pattern. Rest changes may also be visible in probable UIP pattern. Sometimes ground glassing may also be noted, which would be more in a probable UIP, if at all it exists with traction bronchiectasis and other findings, but honeycombing would make the pattern as a definite UIP pattern. Now, this is what honeycombing is. What is honeycombing? These are stacks of small cysts lined one on top of the other. And as the disease severity advances, you may see multiple of these stacks. Where are they? They are usually subpleural, they're usually peripheral. Now, if you look at this versus this, then in these two images, this image also shows some mild ground glass opacity. Ground glassing is not an ideal feature of classical UIP, but in case it exists, we can give the terminology of probable UIP. Now, the typical characteristics of honeycombing, which are these clustered cystic air spaces, always have well defined walls. So you will be able to demarcate each of their walls. They can be seen even in a single layer initially, but as the disease advances, the layers may become multiple, and this is really important for identification. Now, also remember that there will be a reticular pattern, there will be a peripheral bronchiolectasis, and it will always be subpleural and basal predominant. So you can see the tractional dilatation here in this image. And this peripheral tractional bronchiolectasis, which appears as basically tubular arrows, or you can even sometimes see them as cystic structures. This presence of multiples of these again favors the UIP pattern. As in this image that we see here, there's also a concurrent mild ground glass attenuation in the subpleural areas. You can see it here as well. There is some ground glassing, there is some ground glassing here, as compared to this image where there's a clean honeycombing pattern that is visible. Now, this may be a sign of probable UIP, but this image from the text has been mentioned that on biopsy, however, even despite this ground glassing, the final diagnosis was UIP. So we really need to see what is the degree and extent of fibrosis, tractional dilatation, of reticular thickening, and along with the honeycombing. Let's come to the histopath slides. So this is HNE stain, and the radiological features of UIP or probable UIP also have a concurrence on the radiology, on the histopathology. Now this is a low power magnification view, and in this low power magnification view what we see essentially is fibrosis, and we see that the paraseptal and the subpleural parenchyma has architectural distortion. So you can see this distortion in the interseptal and paraseptal parenchyma. And what can be appreciated here is also some honeycombing. So this, if you look closely, is the honeycombing that has been referred to, and this is juxtaposed with unaffected lung parenchyma. So when you see this, then this is the unaffected lung parenchyma, and I shall change my marker so that it's a little more visible. Here we go. So this is the honeycombing, and this is the normal parenchyma, and it involves the paraseptal, or it involves the subpleural parenchyma. The visceral uh, pleura is usually not the one that is more involved. Now, here, when you go to the higher magnification photograph, you also start seeing subpleural scarring, and we also start seeing fibroblastic foci. So, these are the fibroblastic foci. We also see subpleural scarring, and we also see honeycomb changes. Now, when we go down and look at a probable UIP low magnification view as compared to a typical UIP magnification view, we again see paraseptal predominant patchwork fibrosis, but the fibrosis in a probable UIP, the honeycombing change that we see is also not as much. So, the fibrosis is much less developed and there is much less architectural distortion. So, this as the normal area is also here as the normal area. And however, here you can see too much of an architectural distortion. So, there is less destructive scarring, there is less of honeycombing change. And here, what we can see are the fibroblastic foci, which are visible on the higher magnification view. So, there is some patchy fibrosis, there are fibroblastic foci, but the extent of the honeycombing, the scarring is not there. So, here also you can appreciate the extent of the scarring and involvement versus the extent of the involvement here. Coming to the number two pattern, the NSIP pattern recognition. What are the three things that we are looking for? We are looking for subpleural sparing, which is very, very important in NSIP. NSIP also has two types, the cellular and the fibrotic subtypes. The more the fibrotic NSIP, we are expecting it to look a little more like UIP. And NSIP pattern is one of the most common patterns again, and it's also common in multiple other problems like connective tissue diseases. So here is the CT scan of an NSIP. And here you see both the patterns, the non-fibrotic versus fibrotic. When you start looking at the fibrotic pattern, it's looking a lot more like the UIP, but what we see distinctively is the extensive ground glass, which is definitely not there in the UIP. So we can go back a few slides and I'll help you compare, but you see the extent of ground glassing here and here. If this ground glassing was not present and there were rows of honeycombing, it would have become a typical UIP, but the extent of the ground glass makes it a probable UIP. So again, lower lung predominant with ground glass, less of reticulation. You can't see the traction bronchiectasis. You don't see the other signs of fibrosis in a non fibrotic one. And always remember the subpleural sparing. That is typical of an NSIP. If we compare it with the fibrotic NSIP, we see again a lower lung predominance. We see reticular abnormalities all across the lung, and we do see traction bronchiectasis. So here we are seeing traction bronchiectasis, and the subpleural sparing, however, is present. So this is what we describe as the sparing, the subpleural sparing. So this is present. It's symmetrical, it's bilateral, and there is some lower lobe volume loss. And we also notice in a lot of cases that the fissure is displaced because of the volume loss. So NSIP, classically subpleural sparing instead of the rows of um, honeycombing that we see in a typical UIP. There we don't see that here, and we see ground glass opacity as well. You may see fibrosis in the fibrotic subtype, you may not see in the non-fibrotic subtype. So as I mentioned, let's compare UIP and fibrotic NSIP. UIP, subpleural involvement, stacks of cysts, various diameters, all with preserved walls. And NSIP, even though it's fibrotic, you don't see those stacks in the subpleural space. There is subpleural sparing, and there is also more ground glassing here. Let's look at the histopathology of an NSIP. When we talk about histopathology of NSIP, again, it can change as the NSIP becomes fibrotic. And when you look at a non-specific interstitial pneumonitis, which is cellular type, which is non-fibrotic type, you see only moderate cellular interstitial infiltrate. And coming back to, so here it just shows us some infiltrate but mild thickening of the alveolar walls. The lung architecture is well preserved. There are no granulomas here. There is no bronchiolocentricity of the BIP pattern here. When we go to the lung biopsy of a fibrotic NSIP, we can appreciate how the alveolar walls start to be thickened by fibrosis. But essentially, still, there is no architectural remodeling. There are no granulomas, there is no fine honeycombing visible. And when you go to a higher power of this fibrotic NSIP, we see a diffuse thickening of the alveolar walls and fibrosis, but no fibroblastic foci. So when there is no fibroblastic foci, we cannot call it as a UIP. But this becomes an NSIP because there is more diffuse thickening of the alveolar walls. Now coming to the latest and the most recent, bronchiolocentric interstitial pneumonia, or BIP. We'll be hearing this more and more often now because it has been recognized as a major interstitial pattern. Now, BIP is a terminology that is being used for airway centered pathology. That is why bronchiolocentric, airway centered pathology and airway centered during imaging. So you should see it around the airways. You should remember that all the other previous terminologies like HP like pattern or peribronchovascular pattern, they will be replaced with the terminology BIP. So, just like UIP pattern stands for IPF, a BIP can stand for more commonly something like an HP pattern, but then there will be other causes as well. This is the bronchiolocentric interstitial pneumonia pattern, or the BIP pattern, again divided into non fibrotic and fibrotic subtypes. Now, you can really well appreciate here the difference. Diffuse ground glassing with centrilobular nodularity. So, centrilobular nodularity, diffuse ground glassing, no traction bronchiectasis, no signs of fibrosis. This is non fibrotic, centrilobular nodules, diffuse ground glass. Coming to fibrotic BIP, again, usually diffuse, axial and craniocaudal distribution. So, craniocaudal, diffuse, and the classical signs like the three density sign, which had multiple regions of the lung, some with increased density, some with normal density, and some with decreased density, happening along the reticulation and the tractional bronchiectasis. So there is reticulation and traction bronchiectasis. You can see traction bronchiectasis. You can also see the three density pattern, different densities here. And this combination of findings, if you see with the BIP pattern, then it would be given the name of a typical HP pattern. So, when the clinical diagnosis is made and the clinical information is combined along with this radiological finding, with or without the histopath finding, then a typical HP pattern would be a combination of these. So, instead of calling it a fibrotic BIP pattern, then in accordance with the clinical practice guidelines on HP, the typical HP pattern can be represented like this. You may also get scattered cysts like the one here in this pattern. When you come to the pathology, now H&E stain of non-fibrotic BIP and fibrotic BIP. So in the histopathology of non-fibrotic BIP, you would see granulomatous and lymphoplasmacytic inflammation, which will happen within the bronchial walls. And this inflammation will then extend into the alveolar walls from the bronchial walls. So it will be bronchiolocentric. The inflammation will be seen around within the bronchial walls and extend into the adjacent alveolar space. That would be BIP, for example, secondary to HP. When we look at the fibrotic um category of BIP, then we will see bronchiolocentric fibrosis and all the architectural remodeling and airway narrowing and interstitial fibrosis of the adjacent alveolar walls. So, the non fibrotic BIP will essentially have bronchiolocentric findings, and in the fibrotic BIP, here you may get non fibrotic and fibrotic findings, scattered granulomatous inflammation, along with bronchiolocentric fibrosis and interstitial fibrosis in the adjacent alveolar walls. So that would be more typical of the fibrotic. Non fibrotic versus fibrotic. So, why so much importance to BIP? Because when we talk about hypersensitivity pneumonitis, it has been redefined in the BIP framework. BIP is the pattern, it is the imaging pattern or the biopsy pattern. Hypersensitivity pneumonitis is the diagnosis, the clinical history, the radiological finding, the multidisciplinary discussion, and the pathology. You combine these, and that multidisciplinary diagnosis is HP. The pattern, like UIP was a pattern, BIP is a pattern. So you don't need to prematurely label a patient just because of the BIP pattern, because BIP pattern can occur in other diseases also. Some examples given are aspiration, CTD ILD, and drug toxicity. And BIP in many HP like scans will also help avoid the problem of overdiagnosis. BIP will be a pattern. So, when we talk about the BIP pattern, as I mentioned, the three density sign takes a place. And this three density sign, which is three different densities of ground glass, normal, and low density areas, represents air trapping. It also represents changes in perfusion. So, you would see it peribronchovascular, or you can also see it diffusely. When we compare non fibrotic and fibrotic BIP, what are the essential features? When it's non fibrotic, you will have more ground glassing. It will be reversible when the patient's exposure has been taken off. This ground glassing will go away. So, ground glassing with centrilobular nodules will be non fibrotic. If you see traction bronchiectasis, you see the three density sign and you see peribronchovascular reticulation, that will be fibrotic BIP, right? And here, ongoing exposure will turn a non fibrotic BIP to fibrotic BIP. So, not only it aids diagnosis, it also helps you prognosticate the patient. This is a table which is taken from the supplementary information given with this guideline statement. It's a beautiful description of how these various patterns can exist in pathology and histopathology and radiology. So, for a typical UIP pattern, an example CT chest report should write that there is subpleural predominant and middle or lower lung predominant reticulation with architectural distortion, with traction bronchiectasis and honeycombing, with minimal ground glass opacities and lower lung volumes suggesting restrictive lung disease. This is how a sample CT report in a typical UIP should be. Now, based on these findings, the impression should be a typical UIP pattern consistent with IPF or CTD ILD or others. If we are talking about a typical fibrotic BIP, here the findings that should be mentioned should be upper or middle lung predominant. So, upper or middle lung as compared to subpleural and lower low predominant. So, one major difference: upper or middle lung predominant abnormality, diffuse in the axial plane, characterized by reticulation and lung distortion, with again the traction bronchiectasis, but peribronchovascular ground glass and the three density sign on inspiration and air trapping on expiration. So we got all the points here. It's upper middle lung predominant, it's diffuse, it has reticulation, distortion, traction, bronchiectasis, but you also have a peribronchovascular, and that's why it's called bronchiolocentric involvement with the three density sign and expiratory air trapping. The impression would be a fibrotic BIP pattern, and then we would conclude that it most likely, most frequently represents HP, but there are other differential diagnoses. The third is a typical fibrotic NSIP pattern, and how this becomes different is that here we have to mention how it has subpleural sparing. So here it will be middle and lower lung predominant, peripheral but subpleural sparing, predominantly characterized by ground glass opacities, which will not be there in your typical UIP. So, subpleural, ground glass, mild reticulation, and traction bronchiectasis, but no honeycombing here. The impression becomes a fibrotic NSIP pattern that is most frequently seen in CTD ILDs or drug induced ILDs, less common in idiopathic pulmonary fibrosis, and that's how the etiological diagnosis, the lung finding, has to be corroborative. And this is a beautiful way of how ILD is evolving now. Now, the second part of my talk, which is alveolar filling disorders, will be covered in the part 2 of this video. So, stay tuned, subscribe, like, and share Pulmonology Read Aloud. See you in the part 2.